Hello, everybody, and welcome to Individualizing Nutrition Care. This is a health behavior perspective session. I'm delighted to introduce myself, Jason Rocha, and my co-chair, Erin Scallern. And I'll tell you a little bit about us. Erin is a pediatric registered dietitian with a certification in diabetes care and education with 20 years of experience. Her career has spanned adult inpatient care, early childhood intervention, and outpatient pediatric practice. Erin is an outpatient dietitian at Baylor Scott & White McLean Children's Specialty Clinic in Temple, Texas, where she supports children and their families living with cystic fibrosis, eating disorders, and endocrine conditions. She is a weight-neutral, trauma-informed dietitian whose practice is grounded in the interoceptive-driven eating and feeding models of Ellen Satter. Here's our disclaimer here. And we'll introduce our other panelists as they come up to speak. Just wanted to mention that we do have one speaker with a disclosure, and we'll pause on that before they begin.
Thank you for that kind introduction. I'm going to introduce my co-moderator, Dr. Jason Rocha, received his MD from the University of Texas Health Science Center at San Antonio. He is a certified physician. He is certified as a physician nutrition specialist and works as a clinical assistant professor at UT Health San Antonio, where he regularly teaches medical students, internal medicine residents, nurses, and gastroenterology fellows. His clinical focus is providing excellent gastrointestinal care and nutrition support to adults. He is an active participant in the Cystic Fibrosis Foundation's Digest program and is currently creating the first advanced nutrition care clinic in San Antonio.
Thank you, Erin. So I'd like to go over our session lineup today. We're going to have 5 parts. Each part will be about 20 minutes, followed by a Q&A, and with the exception of our last part, which will be a panel discussion, being 15 minutes. And so first, we'll talk about weight-inclusive approaches to patient care in a multidisciplinary setting, the pros and cons of GLP1s, and look at a pharmacist's approach to sensitive discussions. We'll have some special guests join us today to share their lived experiences of persons with body image challenges. And then last part, we'll talk about patient and family counseling in regards to body weight and image. So it's my honor to introduce to you Dr. Stephanie Foligno. She's a clinical psychologist and has been embedded in the CF care team at Cincinnati Children's Hospital since 2009. She's a professor of pediatrics, University of Cincinnati College of Medicine. She co-directs the CF behavioral health program with her physician colleagues, and her research examines mental health promotion, school success, adherence, quality of life, and behavioral nutrition interventions in cystic fibrosis. She's a member of the Cystic Fibrosis Foundation Mental Health Advisory Committee's Education and Training Work Group and serves as a CF Foundation Mental Health Coordinator Mentor. She received the CF Foundation's Carolyn and C. Richard Mattingly Leadership in Mental Health Care Award in 2020. Please put your hands together for Dr. Stephanie Foligno.
Thank you, everyone, for being here. We were really hoping for a packed room, so it's so exciting to look out and see these chairs filled with people who care so much about this topic like we do. Here are my disclosures. So you'll hear me refer to this idea multiple times throughout our time together today, and that is context is everything, meaning everybody's context is going to be different from the changing milliseconds in which we live, and that our current, past, and future are really important for us to individualize our nutrition approaches. So just to give you a little bit about my context, so if you can barely see me up here, it's because I'm 5'2" and shrinking. I've always been short compared to my peers. Before, like junior high and high school, I just felt invisible. I was short, I was thin. It delayed my puberty, which made things really not fun in early high school. And no one talked to me about it. And so I would find myself like making an entire sleeve of cinnamon rolls in high school and like eating the whole thing just to see if I could like trigger my puberty to start. And so I feel comfortable saying that out loud because we all have our own stories about when we were like not feeling great about our body. My predoctoral residency was at a residential treatment center for adolescents, and these were teenagers who had come from really, really rough lives and didn't have a super bright future ahead of them until they came to Boys Town in Omaha, Nebraska. And while there was a really heavy focus on mental health and psychology and psychiatry in that environment, one of the things that was really important to me was how people were doing with their weight-based health, their physical activity and nutrition. And so I initiated a project there that meant a lot to me, and it has since helped Boys Town grow some really fun and individualized physical activity and nutrition programs I'm really proud of. And then I was recruited to come to Cincinnati Children's by Dr. Scott Powers and Dr. Lori Stark, and I served as the interventionist for their behavioral nutrition treatments for pediatric CF and obesity. So that's kind of the runway that got me here. I'm a clinical faculty member. I've been an embedded member of my treasured team for over 15 years, and within my role, I get the greatest joy out of my interdisciplinary partnerships with my team, especially my dietitians, and I'm a leader in our program development and evaluation of different programs we run. I educate psychology and medical fellows. I've traveled to various CF centers and done education days and education settings, and then I also have done some nutrition-based research that I'm really proud of. So when we talk about individualizing nutrition care, one of the things that's really important about this is it allows us to not only accelerate positive health outcomes, but it allows us to improve those health outcomes. And that when we prioritize behavior over health, that helps us include everyone, regardless of what their behavior change trajectory is. It promotes respect, trust, and health in that interaction that is really important for improving outcomes. And then another thing that I really hope for everyone to walk away with today, that there are immense, great, and really important opportunities for us all to develop the professional skills and expertise to incorporate evidence-based strategies in our particular roles to address nutrition in an optimal way. So whenever we're trying to change behavior, timing is almost everything. We have to be ready. We have to think that something's important. And so I stand up here saying it's never too late. It's never too early to work towards being the healthiest that we can be, including a professional who promotes optimal, comprehensive health for others. That's why we're here. It's never too late. So when we think about the what of individualizing nutrition care and why that matters is because in order to have people feel like we're not just giving them one more thing, we need to make sure that what we're doing very easily integrates into their family culture, kind of like a plug and play with some level of ease where effort isn't so high. It just feels like we've got to practice this, but then the effort starts to get easier and easier. And that if we understand the diverse needs of the people that we're working with, not based on age, we can't always make guesses on their health, but we need to understand, do they understand the words that we're using? Can they read the stuff that we're giving them? And do we understand where their systemic capacity is? What are they capable of? And what are the specific limitations? And then how are they guided by their cultural practices and beliefs about one's body, how they eat, if they eat together, what bodies should look like, and what health means. And of course, we feel like we are constantly rushed in our time. And when we feel crunched by that and we don't take the time to develop meaningful, trustful relationships with people, we miss really important nuances. And when we miss things, it affects how honest people can be with us in these sensitive conversations. It affects their motivation and readiness for change. And most importantly, it affects their progress towards goals. And there's really nothing less dissatisfying than when you think you have a plan and then the person and the family come back and they haven't done anything. That feels terrible for them. It feels terrible for us. And the problem is that there wasn't a readiness for that plan. It was just the social desirability of saying, I'll do that, when there wasn't really any readiness and plan to do that. And then, I just have this I am here, but I don't know where I'm going. And I just want to go away from here, but I don't know how to do that. So knowing where people are is really important. So we don't have to be trauma-informed clinicians with hours and hours of training. That's kind of one end of the continuum, which is actually really good too. But in the meantime, we just need to understand and make some assumptions that there's just been some difficulty in the past. Some hard conversations, some challenges, and that we have lots of guidelines that we can follow, but we need to individualize these so that we can meet people's needs. And then we also, I think, are all struggling with these new communication skills that we need to develop around misinformation and when people have low knowledge. At the same time, if we can lean into our skills that we do have of compassion and empathy and active listening, we can probably help understand where people are. I'm just going to breeze through this if you want to take a picture. The point here is just to say assessment tools and evaluations are well described in the growing literature. It needs to continue to grow, but here are some things for you to check out that we won't have time to review today. Also, we want to make sure that we're using our resources wisely. And so if you are on mycff.org, you can find tips for care teams and some really nice resources that people have developed. So, there are these interrogatives like when and why and how. How do we discuss this? I always say to my team, it's not terribly helpful, but it just depends. If you're a New Heights enthusiast, is it new news? Or is it really old news where you've had the conversation over and over again? And I would encourage all of us to continue to brush up on our motivational interviewing and a shout out to PEP training skills. It can be really, really fun to do that as a team. So I've done a lot of motivational interviewing, motivation enhancement work with my team. These are really important skills when people are having ambivalence towards the health trajectory that we are considering to be a direction that would be ideal for them to move. And one of the key things in motivational interviewing is that we match our strategies based on their stage of readiness, meaning if there's no readiness, we don't have a plan. We just continue to work in readiness. And that it is so important, even for grown adults, to remember that small steps are what develop that momentum that we need to do really hard things eventually. And even adults might need some sort of external reinforcement at first to make changes. Comprehensive and individualized care is maximized by all of us putting our hearts and heads together, making sure that we understand how people learn, making sure that we're using our SMART goals so that we can quantify things and help people understand if they're really tracking towards their goals. And then also thinking about these like wider constructs that we can measure. So I'm going to give a shout out to Emma Lyons, who gave a great talk yesterday about self-efficacy and how people feel about their bodies. So maybe like body composition isn't changing, but maybe they've increased the food variety that they've been willing to explore over the weeks, and that we're seeing changes in body satisfaction that may not exactly map on to some of the body composition and other metrics that we may be using in nutrition care. Even adults can do the things that we teach kids: repeated exposure to healthy foods, talking out loud about what you like and what you don't like. Is it too salty? Is it too soft? Do you not like the taste? Do you not like the smell? And that whether you're living within a family or living within a different kind of social cluster, that's an opportunity for positive attending and teaching about foods, and even being together can be a really healthy form of distraction when we're not crazy about the food in front of us. We'd like to be crazy about the food in front of us, but it's not always reasonable. And then you can use this social context to plan your meals and prepare your meals. And we would be remiss if we didn't talk about addressing food insecurity. So when we miss the mark on food insecurity, we are giving recommendations that are not real, and they are not feasible. They are not going to be implemented. So we really have to keep our eyes open to food insecurity, and thankfully on mycff.org, there are lots of really great resources for us to address that within our interdisciplinary context. So when we think about what does this mean in the practical day-to-day of discussing weight, we can use growth charts and weight charts for tools, for understanding, like when you see this, what does this mean to you? And staying very neutral, observing and pausing on our judgment, pausing on that pressure in our environment to move the dial really fast. And that we want to really talk about those connected health behaviors. Physical activity, how's your sleep? Are you getting out and doing things that matter to you? When these other connected health behaviors are happening, we actually may see people moving towards a healthier weight as defined by the care team and the person. And validating experiences of current and past to develop rapport is really important. It's hard for me to say this because I've been talking constantly, but one red flag is if we pause and we go, oh gosh, I've been talking this whole time with a person, a patient, a family, that's probably a sign that we've missed the boat a little bit on building rapport and building partnership. And that's a time for us to really pause, try to do that differently. So Erin's going to really focus a lot on this weight inclusive piece, and so I'm not going to spend as much time as it deserves because I know it's going to be handled by someone far more talented than me. The important thing here is that health behaviors are up here in terms of importance, and weight-centric sorts of measurements are down here. The idea being that if we can move the behavior dial, that we should then see some changes in that other aspect. So, in summary, timing is almost everything. We have to take it slow if people aren't ready yet. That does not mean that it's never. It just means that it's not yet. This is a people-first approach for it to work well. We want to be informed by culture and trauma, discomfort. We want to lean into this strength-based approach. And we really need to make sure that within this interdisciplinary model, we have someone who has really strong training and experience in behavior change. I just could not say that enough. It's one of my most favorite things that I do is I just go sidecar with all of my other colleagues. Like, you get to do the what-based recommendations, and now I can carve out some time to do the how. Please continue to seek training opportunities and evidence-based nutrition and behavioral interventions. One of the most fun things I've done was when the preschool guidelines came out. I'm going to give a shout out to our pediatric teams in Minnesota and Portland. They invited me to come give a team-based training, and everyone showed up. It wasn't just the nutrition, it wasn't the dietitians and the social workers. We had the whole team in that training room. Like, how do we help families get to these nutrition goals? I'd be willing to take that show on the road again. And then we all need to really put our heads together after today about how we're going to continue to accelerate research and clinical interventions in this area. I just did some screen grabs on some information that we can all take a look at, but there was a call out there to say we got to really update this literature to reflect current clinical practices and challenges, which is why we're all here today. And then if anyone wants to read a book by a really incredible psychologist, Emily Sandos wrote this book, Living with Your Body and Other Things You Hate. Highly recommend. And then also, as we're looking for ways to connect really strong clinical innovation and research innovation in other areas that would apply to what we're doing in CF, there's also been some ACT-based interventions for obesity that we could absolutely tap into to build out the effectiveness of our interventions. So I just included one snapshot of that was recently published. And then Erin's going to talk a lot more about the Ellen Satter and Feeding Matters piece, but I just wanted to highlight here that the Healthy People 2030 does include some metrics for us, including the behavioral support for these nutrition interventions. And that while we could talk about ARFID for weeks upon weeks, the only reason I put this up here is because one of the things I love about this line of research is that they're finding that it's not just food anxiety that contributes to food and feeding avoidance, that it's actually disgust, that people are literally, emotionally, and physically and sensorily disgusted by food. And why that is important is because that is likely going to flip us in a totally different intervention pathway than what we're doing for anxiety.
All right. Thank you, Dr. Foligno. We'll be taking some questions if you have any for her. You know, one of the questions that I had is you mentioned building rapport with patients. So I was wondering if you can give us some examples of how in clinic we can do that with people so we can help them to build trust.
Thank you, Jason, for that question. I think the first place, like when we're feeling stuck and we know we kind of have this clinical pressure to like change things, move the dial, we really need to start with open-ended questions. And it doesn't even have to be about weight. It doesn't have to be about nutritional status. We can ask about, so, you know, what are you thinking about whether or not your favorite TV show should have another episode? Really, like, I know we don't always feel like we have the time to do that, but the open-ended questions allow us to talk about something that like breaks the ice. What we're all here talking about today is like a pressure cooker kind of conversation. And we have to connect on a human level. So I think breaking the ice was something that may be peripheral related, but really we have got to stay in this like open-ended question, like, tell me what you think about this. Like, what's been the easiest thing about this weight change journey that you've encountered? And then we just be quiet for a while. And that is really hard. We're all like feeling pressured for change. And so when we ask a question in an open-ended way, the way that we show people that we really care about the question is that we don't start going right after they say something. We reflect it back and you go, whoa, that's actually not something that I knew about you. That is really cool in an authentic way, right? Thank you for telling me. That makes me wonder, ... And then you go on to your next open-ended question. I hope that, yeah.
Dr. Foligno, we have one more question. Do you think you can use this approach in a group setting? Can patients support what other, we'll just say in a group setting.
I understand the question in terms of efficiency. So group interventions tend to be pretty efficient in allowing us to not have one-on-one. It also has the benefit of that social structure. I honestly am telling you the truth here that I don't know the literature very well on group-based interventions for this. I would welcome other people to talk about that, but what I can say is there are group-based interventions for really sensitive topics in the mental health world. So it's not impossible, right? We have self-help or we have group-based interventions for people who are actively suicidal. They're engaged in self-harm. They may have all have their own version of abuse history. So it's not impossible and it's not against the law, right? But I do think if we're going to do group-based interventions, we have to be really clear about what our objectives are. And we really need to set some ground rules because I can imagine for people who have any level of discomfort or trauma, that this could be a really tricky area with some landmines that we'd want to watch out for to assess benefits and risk ratio.
Thank you. We have one question over here.
Okay. Can you hear me okay? Yes.
Yes.
Dr. Foligno, wonderful talk as always. Thank you for sharing all of that and your expertise with us today. This is such an important topic. And I always ask speakers who talk about health behavior as opposed to that weight-centric model. I think a lot of us in this room are sort of already, really focused on health behavior as dietitians or mental health professionals. We might have some members of our care team that have not quite come on that journey with us yet and are still very weight-centric and weight-driven and don't take an individualized or health behavior approach. What's your advice for helping entire care teams kind of come along into this way of thinking?
Okay, now I love this question. I think, thank you, because this is one of the things that I've loved seeing my team evolve. Sometimes I feel like when I close my eyes, I'm in a room with psychologists. My team has really become so psychosocially minded, and everyone is going to engage in their own clinical behavior change at their own pace. We all do have that unifying goal of healthy, happy people. And so I think that when people who are slower to change can see the clinical human evidence in front of them, whether that's where we present a case, or they observe, I'm come in the room as I'm having this conversation with them. You don't have to say anything, but I just want to sort of have you get behind the, psychologist curtain a little bit and just see how I do it. And so there may be some things that I'm saying, some things that I'm doing that you're oh, I think I could actually plug and play that into my way, keeping in mind they're not going to change overnight. But if they start to see the change themselves, I think they're just going to catch on to it like fire. And I will tell you, I've seen it in my own team, so I know it can happen.
All right. Thank you for that. We'll hold the rest of the questions for the panel discussion.
I have the pleasure of introducing Dr. Missy Norton, a board-certified ambulatory care and advanced diabetes management clinical pharmacist and recognized leader in chronic disease management and cystic fibrosis care. Dr. Norton works at Ascension Via Christi Hospitals in Wichita, Kansas, where she plays a key role in interdisciplinary care for pediatric and adult patients with complex health needs. Missy has improved medication access and health outcomes for underserved populations. She is currently recruiting patients for a prospective research study to evaluate continuous glucose monitors for glycemic evaluation and screening of cystic fibrosis-related diabetes. Dr. Norton has been a longtime volunteer and partner of the Cystic Fibrosis Foundation and recently earned the 2025 Pillar Award from the Foundation's Heart of America chapter. She also serves on the editorial board of the Kansas Journal of Medicine and as an adjunct clinical assistant professor at the University of Kansas School of Pharmacy, where she mentors the next generation of pharmacy professionals.
Thank you so much for the introduction. I am really excited to be here, especially to talk to you about one of my favorite classes of medication. So as a pharmacist, it's a requirement that I have to have a favorite, and this is one of them, this whole class. So we're going to talk a little bit about pros and cons of GLP1s. I know that's kind of a hot topic, both in the CF world and outside. As well as approaches to have these very sensitive and delicate conversations with our patients. And so we're going to describe the weight challenges in CF with highly effective modulator therapy, review the mechanism of GLP1s, explain some tips and approaches to discussions around weight loss, as well as summarize appropriate and safe use of GLP1s in people with CF. So when it comes to nutrition, historically, there is kind of a push for increased BMI, increased weight, in order to preserve lung function and decrease mortality and complications in CF. So this direct relationship is between the nutritional status of our patients and their pulmonary outcomes and mortality. And appropriate treatment of malnutrition has been a long-standing hallmark of CF care. There's this push for these high-fat, high-calorie meals or the legacy diet, adding additional nutritional supplementation to tip the scales into those positive outcomes in our CF population. However, we are in the era of highly effective modulator therapy, and so we've had a shift in this CF nutrition landscape. So what we would expect when starting highly effective modulator therapy is an increase in weight, an increase in their lung function, a decrease in complications and in mortality. However, our scales, pun intended, have tipped a little too far in that positive direction. And now in the CF community, we're dealing with new challenges such as obesity. And so while historically weight gain is very welcomed to improve lung function, obesity can actually work against us in terms of lung function. And so now clinicians are faced with having to shift from preventing malnutrition to balancing that metabolic health in our CF patients. And so these shifts have really led our providers to start to think outside the box when it comes to the weight gain that highly effective modulator therapy has given our patients. And when thinking outside the box, some people may go to the GLP1s or the glucagon-like peptide-1 receptor agonists. So in this diagram, you can see the central and peripheral effects of the GLP1 receptor agonists. And so when I think about the main body systems that are affected by GLP1s, I think of the pancreas, the GI system, and the brain. And so in the pancreas, this was the initial focus of GLP-1 therapy. So the GLP-1s stimulate insulin release from the pancreas in a glucose-dependent fashion. So it also helps, because of this glucose-dependent fashion, with postprandial glucose excursions most. And because it's a glucose-dependent blood sugar lowering, you also have a very low risk of hypoglycemia, which is also why this class can easily be used in people without any kind of impaired glucose tolerance or diabetes. And so the GLP-1s also will decrease glucagon secretion, which in turn prevents stored sugar from being released in the absence of hypoglycemia. This is a phenomenon that happens at a higher rate in people with diabetes than those without. So your results are that you have improved glycemic control, lower A1C, lower fasting blood sugar, and especially those lower postprandial glucose values. So the GI system is the second one I think about, mostly the stomach. And so the GLP-1 receptor agonists actually slow gastric emptying. And so when they do that, your GI transit time is slowed. You feel full, easier, faster, and for longer, which can lead to weight loss because you eat less, you're eating less frequently, you have lower caloric intake, and that can lead to weight loss. So in the brain, the GLP-1 receptor agonists actually help to suppress those hunger signals that we all have. And so if you have decreased appetite and increased satiety, it's going to lead to eating less, and then you're going to potentially lose weight. So I tell patients all the time, it's actually the side effects of the medication that work to our advantage for weight management. And also, weight loss alone has been able to show to improve insulin sensitivity. So it fights that mechanism of insulin resistance that happens in all types of diabetes. And so there are a lot of advantages to this class of medications, the GLP-1s. They have been shown in clinical trials and in practice that they have multiple benefits. So that first one, the initial focus of GLP-1s, is glycemic control. So as I mentioned, they're very effective at reducing blood sugars, especially those postprandial blood sugars, which improves overall glucose control and A1C. However, that side effect profile, as I mentioned, also helps with weight management. And so you can have a pretty effective weight reduction with the GLP-1 class of medications. So effective in that the clinical trials actually show anywhere from about an 8 to 24% on average body weight reduction after a year, with varying degrees as well. But one of the reasons this is one of my favorite classes of medications is the cardiovascular benefit. And so this class, along with any class that has been evaluated to be used in patients with diabetes, has to undergo cardiovascular outcome trials. And because of that, this class overwhelmingly has shown that it can reduce the risk of heart attack, stroke, and other major adverse cardiovascular events. One study in particular showed up to a 20% decrease in the relative risk reduction of MACE, or major adverse cardiovascular events, which is pretty significant. In addition, more recent studies have shown that this class can be renal protective. And so for patients with chronic kidney disease, it actually slows the progression. So you can actually protect kidneys with this class as well. There have been additional emerging benefits that are starting to be evaluated, such as in heart failure. Some studies, not all, have shown that it improves symptoms and functional capacity in patients with heart failure. This class has also recently been approved for MASH, or metabolic dysfunction associated steatohepatitis. Don't say that one fast. There's been one of the molecules recently approved for obstructive sleep apnea, because a reduction in weight is significantly going to help with sleep apnea. And then for future exploration with this class, they're looking at neurologic, dermatologic, and respiratory benefits. And so as you can see, there are several benefits to this class of medications, which are part of the reasons why I like this class so much. So with all medications, there's of course a list of cons as well. And for the GLP-1s, the number one con is going to be the side effect profile. And every patient is different. Some people experience significant side effects and others experience very little. However, those GI side effects are going to be common, nausea being the most common. You could potentially have vomiting, delayed gastric emptying, constipation, and/or diarrhea. And because of that side effect profile, we really need to think about nutritional status. In our CF population, this is especially important because it could potentially worsen malabsorption and nutrient deficiencies. And with our CF patients in particular, body image concerns are very complex. And so there's a stigma around weight loss medications, and so we want to be mindful of body image as well. And perhaps one of the largest barriers is actually cost and access. And so this is not a cheap class of medications. Cash price for a month of these medications, anywhere from about $800 to $1,500 or $1,600. Again, that's cash price. So as you can imagine, insurance often can push back on approvals for these medications. And in the last couple of years, it's actually gotten significantly worse as this class of medications has become very popular because it is so effective at reducing weight. And so many insurance plans no longer cover medications like GLP-1s for weight management specifically. And I wouldn't be doing my due diligence as a pharmacist if I didn't talk about the contraindications and precautions that go with this class of medications. And so the two main labeled contraindications in the package insert are history or personal history or family history of C-cell thyroid tumors or multiple endocrine neoplasia syndrome type 2, both of which cause thyroid tumors. And so in the rat model early in studies, they actually saw an increased risk in thyroid cancers, but they were rare types of thyroid cancers. And so that's the main reason it is in the package insert as a contraindication. This is actually never translated to humans, which is great. However, something to be mindful of. But when thinking about CF, a contraindication that I would consider would be a patient with severe malnutrition or a patient that's underweight. This would not be an appropriate class to start in that type of population. There are also some precautions that need to be kept in mind, but are in no means an absolute no, you can't start the medication. And that would be a recent history of acute pancreatitis. Now, more recently, there's actually been a meta-analysis done that looked at risk of pancreatitis in the entire class of GLP-1s and actually saw no risk of pancreatitis. So we now have information on GLP-1s used in patients with pancreatitis, but it is still a concern that you would want to evaluate if you wanted to start one of these medications. Another thing to be cautious about is gastroparesis. So as I mentioned when talking about the mechanism of this class of drugs, they do slow gastric emptying. So mild gastroparesis typically isn't a problem. However, if you have more moderate or severe gastroparesis, probably not a great drug to start because it's only going to make it worse. And the same goes for acute gallbladder disease. In our CF population, this can also be a problem. However, rapid weight loss also can cause gallbladder problems. And so you would want to keep that in mind if you're going to start this medication class. So let's think about who the appropriate patients are to start a GLP-1 in. So I kind of think of two main categories, your overweight and obese population of your CF population, and then your CF-related diabetes population. And if you notice in the obese and overweight categories, I have two different BMI targets. BMI of 30 or greater, with or without complications or comorbidities, and then a BMI of 27 or higher with one weight-related comorbidity. The reason I have these broken down into these two BMI categories is because of insurance approval. Almost all insurances will typically follow this BMI cutoff in order to get the medications approved specifically for weight management. So with CF, you can consider CF-related diabetes, weight-related comorbidity, although I think we could all argue that a little bit. But hypertension, dyslipidemia, anything that you think of in terms of a weight-related comorbidity would count with that BMI of 27. And then we think of our CF-related diabetes population. So if you have a patient that maybe isn't meeting their glycemic targets and needs additional glycemic control, I've actually found that the GLP-1s can replace mealtime insulin if at lower doses. So more in like the single digits if I had to give you a number. Again, they're going to work on that postprandial glucose elevation most. And so it's going to be very similar to your mealtime insulins. Also, an added benefit that you can get for anybody with diabetes in general is a reduced risk of cardiovascular events. Actually, we all could use that, I think. And then if you can also protect their kidneys, another great benefit in patients with diabetes. So if you do have a CFRD patient that maybe needs extra glycemic control, maybe early stage CKD, this could be a good option to get multiple benefits. However, this has to be in a patient that could manage a little bit of weight loss, in which that weight loss would be acceptable. So the weight stigma in CF is very complex. However, as a pharmacist, I find myself very well positioned to have these discussions about weight. These are very delicate conversations for some patients. However, other times you may find patients that are just very open to talk about it. I'm in a position in that I know my patients very, very well, and so often they come to me, which is great. However, I do want to give you some tips if you don't have a patient that's willing to open up about these topics. So the first thing you want to do is create that safe and respectful environment. You want them to feel comfortable coming to you and talking to you about these sensitive discussions and these sensitive topics. You also want to be mindful of your language, using neutral, non-judgmental terms. So for example, instead of saying overweight or obese, talk about nutrition and BMI. Or maybe instead of saying exercise, use the word activity. It kind of spins it into a little bit more positive tone. You also need to, as Stephanie had mentioned, use your motivational interviewing skills. And one of the keys to motivational interviewing is those open-ended questions. So you can actually get the answers you want by asking open-ended questions. And so often you may not have to broach the subject directly. So if you do have a patient that you're having trouble actually getting them to talk about weight, you could say something like, tell me how you feel about your eating habits and about your weight, and get them starting to talk about that. However, I like to use kind of a positive and negative type of questioning. And so one question in particular that I think is very effective, because it's most common right now with these weight problems in our CF population, is talking about ETI. And so I say, tell me how ETI has improved your life. And so you may get answers like, well, before, I would spend an hour or two every morning just clearing my lungs out and getting ready for my day. And I don't have to do that anymore. I wake up feeling good. Or you may get an answer like, you know, I used to get winded just walking to the end of our country road to go to my mailbox. And I no longer am winded getting to my mailbox. So now you flip it into a less positive questioning. And then you say, okay, that's great. I love to hear that. But tell me what challenges you've had since starting ETI. And you may get, well, I told you I've kind of had these headaches almost every day. Or if you're trying to broach the subject of weight, maybe you'll get, well, I really don't feel comfortable in my body anymore because of how much weight I've gained. I always feel bloated. My pants don't fit. I'm just not comfortable anymore. And now you have reached a point where the patient has started that discussion and you don't have to. And this also gives you a really good opportunity, and Stephanie just nailed it. She didn't even know I was going to talk about this, but about that reflective listening. And so this is your good opportunity to validate their emotions. And so you can make sure you recognize those frustrations, you recognize their body image concerns, and you use reflective listening skills. So this is a perfect time to say, so what I'm hearing is that you're very thankful for ETI and the benefits that it's given you. However, you're very uncomfortable with the weight that you've gained. So not only have you used your open-ended questions and your motivational interviewing to get the patient to acknowledge their struggles, you've now validated their feelings and just repeated back to them and validated those struggles that they're having. So very effective if you can use it effectively. And when kind of coming to those decisions, if you do have, get to a point where a patient's ready to really start talking about options to help with weight management, make sure you share information very thoughtfully so you can come to those shared decisions. And I like to guide the patient to identify their own goals without a focus on the numbers. So start focusing more on those functional outcomes like body image or increasing energy. And then as a care team member, I would also add in, not only can we help you with this added weight that is weighing you down, we can help you with your CF-related diabetes, and we can protect your heart at the same time. So I make sure to always add in those additional benefits. You also want to present these weight discussions as part of just routine CF care, not just a judgment. So there can be a lot of struggles for patients when they first start GLP-1s. The initial struggle may be that they've finally had to really address their body image issues and their weight that they're uncomfortable with. They may also have a fear of losing that stability that they have with the added weight, because for years we've told them, you need to increase your weight, you need your weight up, you need your BMI up because your lungs are going to be healthier. And so there could be a fear that they would lose that stability. And again, it's confusing. We've told them for so long that you need to eat more, have more calories, high fat, and now we're saying, well, we're actually going to start this weight loss drug. So it's a mixed message to them. And there can be some concerns about the side effect profile and how it could potentially interfere with their CF care, or having persistent nausea, those early symptoms, not only at the start, but as they continue on the medication. I think it's also important to talk about when we should stop a GLP-1. So if a patient has severe persistent GI symptoms, that's a pretty easy sign that maybe we need to stop GLP-1 therapy, including acute pancreatitis, despite some of the literature saying that it doesn't actually increase the risk. If they have excessive weight, including muscle depletion, you may need to stop or at least interrupt therapy. If they have a declining nutritional status, despite supplementation and counseling on nutrition, that would be an indication to stop. Obviously, patient preference, or if you have worsening CF outcomes. And when discontinuing this class of medications, there are some struggles that come along with that. So there could be a fear that they're going to regain weight, which is a real fear. A lot of times when people stop this class of medications, they do regain some of the weight. However, if they're able to stay on the medication long enough, the hope is that they've made some true lifestyle modifications to be able to continue healthier eating, healthier portion sizes, and things like that. And they may have feelings that they failed or they disappointed their team, but just reassure them that discontinuation is not a failure. Their body image concerns may continue as their weight fluctuates, and they may also have trouble with overeating because they no longer have that medication there that stops those hungry signals. So I want to talk a little bit about how I would counsel and manage when starting and continuing and stopping GLP-1s. And so at the start of therapy, I set very realistic expectations. I talk very much about the GI side effects and that they will likely have at least one, even if mild. And I make sure to tell them that there's ways proactively we can hopefully prevent some of those side effects. And the biggest one is to reduce portion size before you even start the medication and know how it affects you. Reduce your portion size, give it 20 minutes. Then if you're not having any nausea or anything like that, then finish your meal or have a little bit more. Also increasing good protein and fiber can help. So again, proactively telling them how to manage those side effects is very helpful. And then as a pharmacist, I always counsel on the drug itself and administration. And so each of the approved GLP-1s out there may have a different device. And so knowing the device, knowing how to teach the patient to use the device, and then having them reteach that back to you is very helpful. When continuing therapy, we always look at symptoms. I always ask them, how are you tolerating your GLP-1? And make sure that we don't need to intervene in some way. However, if we do, I make sure they have good hydration in case they're having nausea, vomiting, diarrhea. We need to keep hydration. They're reducing their portion sizes, they're getting good protein, and in some situations, it may be that they need to just back off the dose a little bit. I also want to make sure that they're meeting their weight management goals safely and effectively. So typically recommending about 1 to 2 pounds of weight loss a week, or 5 to 10% weight loss within about 3 to 4 months. However, that can vary depending on the patient. So discontinuing therapy is another point in which the patient needs a little bit of counseling. We would talk to them about what to expect, that those hungry signals would come back, that hopefully they can continue to modify their portion sizes and make good food choices so that they can support healthy weight moving forward. So I think some of the key takeaways are that we all know that highly effective modulator therapy has really shifted our nutritional challenges. And GLP-1s are a reasonable option to help people that need some weight management and or blood sugar control, cardiovascular risk reduction, all of the great things that I talked about. However, they require careful individualization in patients with CF. And as a pharmacist, as well as other care team members, I feel like we're able to help them navigate those sensitive discussions, as well as monitor therapy all through starting, continuing, and discontinuing. Those are my references, if anybody wants them. What questions do you have?
Thank you, Dr. Norden. We did receive a few through the online chat, and Erin's going to ask them.
Okay. So because of the high prevalence of sarcopenia with CF patients, should we be getting a body composition before initiation of GLP-1s? And then additionally, because rapid weight loss is associated with decreased muscle mass, is that another reason to discontinue the medication?
That's a good question. In terms of the rapid weight loss, in my CF population, we take it much slower than I would with a typical patient that is looking for weight management. So we don't rush the weight loss. So I think that helps. The muscle depletion is not necessarily a direct effect of the drug. It's that most people cannot effectively lose weight without exercise and without increasing activity. And so making sure that we're counseling on the importance of that so that they don't lose muscle mass is also a really important aspect. So, did that answer
And one question over here.
Sorry, I'm really short. These mics are like for tall people. Okay. Thank you so much for your talk. Really informative, and you clearly have a ton of experience. Didn't you say about 15% of your patient cohorts on these drugs?
Yeah, so I was kind of doing the math, and I was like, we have about 15% of our adult population on GLP-1s at this point.
Wow, that's a lot. So my question for you is, how do you work with the psychologist or social worker and the dietitian on your team to navigate these complex issues, and even the physical therapist, since exercise is, as you just said, a huge part of this? Like, what's the multidisciplinary strategy that you're sort of embedded in? And could you say more about that?
Yeah, that's a good question. The biggest component is going to be myself and our dietitian working together. Like I said, most of these patients, we don't have to broach the subject. We know them well enough that they come to us. However, I know that's not always the case. We have those patients that don't want to bring it up. And that may be where you pull in your psychologist more and your social work to kind of help with the people that maybe need a little bit more discussion around these sensitive topics. When it comes to myself and the dietitian, I think we do a pretty good job of kind of working together in that aspect. Also, a little plug, we're about to lose our psychologist to retirement. So Wichita, Kansas is looking for a new one if anybody needs a job. So.
All right, we're going to, one more question over here.
Hi, Caitlin Jacobs at Children's Wisconsin. So we are using it in the pediatric population in GI clinic, endocrine clinic. We haven't had any patients within CF that we've started on these meds. Part of me is concerned to start it in a teenage population given body image issues, but then also concerns for if they have to come off the meds and the harms of weight cycling, as we know that that can then mess with the metabolic process. So in the adults, do you like, because it's 15% of your patients that have to or are on it, do you know like percentage that has had to stop it? Have there been concerns with weight cycling?
It kind of varies a little bit on who maybe would need to stop and just discontinue altogether. I think Erin's going to cover the weight cycling part of it, so I'll let her do that. In my experience, sometimes one GLP-1 gives someone more symptoms, and switching to, or there are some pins out there that can be modified. I'm perfectly comfortable modifying the standard dosing to help a patient better tolerate their GLP-1s. I know that's not like an approved method, but if we can get them to their goals safely and they can tolerate the medication and get the benefits of it, we're absolutely willing to do that. So that answered most of your question.
Yes. And then one more question really quick. So with Wegovy, at least in pediatric patients, they have to show percentage of weight loss for continued insurance coverage. If we're trying to aim for slower to like protect muscle mass, have you had good luck still getting coverage at those reduced doses?
Sorry, I didn't hear the question. It's echoing really bad. It's echoing really bad. I'm sorry. I'm having trouble hearing you.
She was asking, is it okay if I paraphrase your?
Yes. I think it's my hearing aid messing with it.
Okay. She was saying with pediatric patients, there has to renew it.
Discussion. We'd like to move on to our special guest. We have Alex Gant, who's going to be joining us virtually. And as we switch over on the screen here, this is a lived experience that she's going to share with us. And just to let you know, Alex Gant was diagnosed with cystic fibrosis at 9 months old, and she recently turned 40. She lives in Colorado with her husband and their fur babies, two incredibly rambunctious labs. She was born and raised in Austin, Texas, but moved to Colorado about 8 years ago to enjoy a world without humidity and discover what it is to have 4 seasons. Alex is an avid reader who also enjoys camping, jigsaw puzzles, video games, and spending time with her precious nieces and nephews. She is passionate about forming relationships in the CF community and hopes to continue to raise awareness about CF in the general public. So everybody welcome Alex for joining us. Oh, okay. Go ahead, Alex, if you hear us. We do have a video we can play if we're not able to get it connected.
So sorry everyone, I have no audio on my end, so I couldn't hear that it was my turn to talk yet. So sorry about that.
No problem, Alex, go ahead.
Hi everyone, my name is Alex Gant, and I was diagnosed with CF at 9 months old. Today I want to talk to you about the difficulties of trifecta weight gain and how it feels as a person with CF to suddenly have to worry about weight for the first time in their life. So cystic fibrosis is an invisible disease, but it does impact the body in physical ways. The first time I had a PICC line scar, I was so embarrassed. And when I got my port inserted, I was so worried that seeing it in the mirror every day would make me feel sick all the time. These days, I also get to sport oxygen 24/7, but that's a story for another time. But no matter what CF put me through, I never once had to worry about my weight. I was always thin without even trying. And as a child, I was quite underweight. I remember one summer, my parents instructed my grandparents to try and stuff me with food for a week in hopes of me gaining a little weight. They gave me any food I wanted. It was mostly Butterfingers, if I recall correctly. But at the end of the week, I had gained maybe half a pound only. So food and weight was just never something I had to think that much about. So I was quite thin for most of my life, and then Trikafta came around. This so-called miracle drug was working wonders for some friends of mine, and I was so excited by the prospect of not spending months of my life on IVs anymore. I didn't expect the headaches, the mental health issues, the dizzy spells, and the rash, but most upsetting to me was the massive weight gain. I'm only 5'3", so any amount of weight is going to look bigger on me, but I gained an astounding 65 pounds. I realized immediately that it was the Trikafta. After all, I do know my own body. But when I tried to convince other people, I was told that, 1, it's COVID lockdown and everyone's gaining weight, and 2, it's calories in versus calories out. So just eat less and exercise. So in other words, what I heard is that it's all my fault and I could prevent it from happening. So imagine my surprise when, after going on a crash diet and committing myself to the treadmill 3 times a week for a month, I didn't lose a single pound. Once again, I was told that I was doing something wrong. A dietitian at my clinic suggested I go over what I was eating with her. And when I said something about occasionally grabbing a Pop-Tart for breakfast if I was running late to do my breathing treatments, she more or less kind of blamed that on my weight gain. 30 pounds in a month because I occasionally ate a Pop-Tart when I spent my entire life being forced Scandi shakes and Scandi bars and Ensure Plus and being told to eat double the portions of everything. It didn't add up for me, but from then on, it felt like everyone was just blaming it on my eating habits. So let's talk about eating habits for a moment. I'm 40, which means for almost my entire life, I was told to eat things with lots of calories and fat, to pour salt over everything, and to drink hugely caloric and fattening shakes if I wasn't feeling well enough to eat. I was once told as a teenager that an average person should eat about 2,000 calories a day, but I should eat 4,000. That was absolutely physically impossible for someone of my size, but they were just always trying to stuff food in me during hospital admissions. All of my portions came doubled, and they used to send something like 3 helpings of a dessert and a snack that consisted of an entire sandwich, chips, and a Coke with every single meal, even breakfast. Then I would be chastised for not eating enough. And one time as a teenager, they didn't even want to discharge me because I'd lost a little bit of weight during the visit. Never mind that I get sick on IVs and I spent most of that time vomiting. All they really cared about was the number on the scale. So take someone with this kind of background and suddenly throw them on a drug that packs on the pounds very quickly. And how can I be blamed for this? I don't know about other patients, but I was given no guidelines on how to change 30 plus years of eating practically overnight. When my ankles and feet began swelling, I was told I needed to cut down on my sodium. Naturally, I was still downing everything in salt since I was told to do that my entire life. And I actually felt ill if I didn't get enough salt in my diet to counteract how much salt I lose through sweat. But now all of a sudden, I was being told I couldn't have salt anymore. Everything tasted incredibly bland, and it seemed like no one had any solutions to fixing that. So as I continued to put on weight, I felt incredibly down and very alone. I watched other CF friends of mine begin to live these amazing lives, with Trikafta doing wonders for them. And while some of them did gain weight, it was usually like 15 pounds or so. Nobody was packing on the pounds like me, but I also wasn't seeing an improvement on Trikafta like everyone else was. I felt very isolated and very ashamed. And when I tried to complain to family members, they told me I just needed to be grateful for the drug. I felt very vain being concerned about my physical appearance, but I am only human, and I think anyone who says they don't care is probably lying. But even more than how I looked in the mirror, my body was suddenly foreign to me. My feet were always hurting, my knees were swollen, I couldn't fit into any of my clothes. It was just really hard. I even developed sleep apnea as a result of my new weight, and I became extremely sedentary because everything hurt if I tried to move too much. So looking back, I don't feel like anyone really warned me about these weight gain possibilities. And no one really helped me once I gained the weight. Everyone just seemed confused on why I gained so much more than everyone else. And that's where I always felt the guilt and the shame. I couldn't help but think, is something wrong with me? Am I just eating too much? So after 2.5 long years, I finally stopped Trikafta. And within a month and a half, I'd lost 19 pounds. I finally felt vindicated. I had told everyone in my life that it was the Trikafta making me gain weight, and it felt like this was finally the proof. Unfortunately, I did end up developing Cushing's syndrome from being on Trikafta, so I've now been battling to get all the weight off for the last 2 years. I'm still in a body that feels very foreign to me, but at least I know I can lose the weight once we sort out all my Cushing's issues. So obviously, my problem ended up being a little more extreme and unusual than most others. But whether it's 65 pounds like me or only 10 pounds, it seems like a whole generation of people with CF were suddenly thrown in a world where calories actually matter, too much salt is bad for you, and maybe a piece of cake every day is no longer considered healthy. Trikafta has been out for almost 6 years, and yet I personally haven't really seen much of a change at clinic. The dietitian still isn't talking to me or most people that I know about how to change our lifelong eating habits. I was recently told by a friend of mine that her doctor told her that an alarming amount of people with CF are now considered overweight or even obese on the BMI scale. So it's my hope that clinics don't keep burying their heads in the sand about it and actually discuss it head on. It might be embarrassing to point out to a patient that they've gained weight and need to reevaluate their eating habits, but trust me, you're not telling them anything they didn't already know. Pretending it's not happening is just going to lead to a slew of overweight CFers with high blood pressure, high sodium, and diabetes. It's not too late to fix it, but first it does need to be acknowledged. Thank you very much.
We're going to save questions until both of our speakers have shared. So I am going to introduce Matthew Pick, who was diagnosed with cystic fibrosis at the age of 15 after years of receiving misdiagnoses. Determined not to allow CF to define him, he dedicated himself to his studies and received his bachelor's and master's degrees in computer science from Stanford, including a full academic scholarship for his graduate program. For the past 10 years, Matthew has worked at Microsoft as the senior project manager for Windows onboarding, leading his team to build all the PC setup flows seen by billions of users across the globe. Matthew has volunteered as a mentor in the CF Foundation's Peer Connect program since its inception. Specifically, he helps students with CF navigate college, jobs, and parents of the children with late diagnoses adapt to their family's new reality. Matthew currently lives in a suburb outside of Seattle with his wife and 10-month-old daughter. He enjoys skiing, snowshoeing, hiking, and kayaking in his free time. You can often find the Pick family on a mountain trail or paddling the lake together.
And Matthew, you're on.
All right, can you hear me now?
Yes, we can.
Wonderful, thank you. As I said, Halloween 2007 was the day I stopped breathing. Growing up, I had exhibited all of your classic CF symptoms, and although I was in and out of different doctors' offices, none of them could figure out why my health was continuously declining. Everything finally came to a head that fateful Halloween morning as a freshman in a new high school, when I finally found myself suddenly unable to take a breath. It felt as if my lungs were balloons, trying to inflate, but someone was pushing back against them from the outside. While terrifying, this sequence of events led me to Children's Hospital Los Angeles, where I was finally diagnosed with cystic fibrosis at the age of 15. As I committed to learning about my new diagnosis, treatments, and nutrition plan, my relationship with food also changed. You see, prior to my diagnosis, I was doubled over in excruciating pain anytime I ate fat-containing foods. Even without a proper CF diagnosis, I learned which foods to avoid and ate only a diet of lean chicken and rice through trial and error. I actually developed a disgust towards any fatty foods from years of this Pavlovian conditioning. But now, with my CF medical team, I was encouraged to try all of the foods I previously disliked, and I had to relearn my relationship with food itself. From years of extreme dieting, I was 15 years old, 70 pounds, and my doctors described my appearance as cachectic. But finally, with the blessing of pancreatic enzymes, I could eat a normal CF calorically dense diet and began gaining weight. To encourage rapid weight gain, I was told to eat as much as possible, including cheesecake for breakfast and milkshakes after school. I was the envy of all of my friends. I distinctly remember my medical team telling me from my hospital bed that in just a few months' time, I would look and feel like a different person. And indeed, that was the case. There we go. And indeed, that was the case. Over the next year, I gained 35 pounds and got to a healthier weight from my breathing therapies. I recall one day looking in the mirror, but not recognizing the person looking back. I was changed, both inside and out, and I embraced my new lease on life, but there was a significant mental and physical adjustment period to accept that this was indeed the new me, and that my weight and looks were both normal and still healthy. Now, fast forward 12 years, and my life once again changed with the introduction of Trikafta. Prior to Trikafta, I had always been active, but my respiratory limitations impacted my level of physical activity. But now, with this new miracle drug, I had both the energy and stamina to double down on my existing outdoor hobbies in a way that were previously impossible. I had a new lease on life, and I wasn't going to squander it. Whether it was hiking, kayaking, skiing, snowshoeing, tennis, I embraced all of my new capabilities and explored my new limits. I even began training for a 5K run, since I was never able to jog before due to my limited air intake. On Trikafta, I was the most active I had ever been. Yet, even as I was burning more calories, I was also gaining weight. When I first started Trikafta, I was informed that some weight gain was expected, but that it would bring me from being chronically underweight my whole life to within a healthy range. Retaining weight had always been a struggle, so I was excited to have one less thing to worry about when managing my condition. Before Trikafta, my weight fluctuated between 125 and 130 pounds. However, 5 years later, I had gained 30 pounds and weighed my personal heaviest, on the high end of normal for my height. I felt as if I had come full circle from when I was first diagnosed at 15. Just as had occurred 12 years earlier, the price of a life-saving medical intervention meant I once again gained another 30 pounds and had to adjust to the new me, both good and bad. The words of my former doctors at Children's Los Angeles echoed in my head as I once again looked in the mirror but didn't recognize the person looking back. But please don't take this for ingratitude. I was and am endlessly thankful for the new life that Trikafta has afforded me. And with those healthy changes also came physical and mental adjustments regarding body image that I just hadn't anticipated or been fully prepared for. At my next clinic visit, I asked my dietitian about whether my current weight was still healthy for me, and we developed a weight loss plan together. To ensure I was losing weight at an appropriate rate, we configured a calorie counting app to help me stay on track and provide nutritional insight. Truth be told, I came home from that clinic visit incredibly distraught. It wasn't about anything that my medical providers had said. I just had never before been unhappy with myself because of my body weight for being too heavy. For over a decade prior, since being diagnosed with CF, I was desperately trying to increase my weight and caloric intake. But now, I was having a bit of an identity crisis, coupled with uncertainty if I'd even be able to lose weight regardless of my level of commitment. Weight loss was something I'd simply never attempted before, and I didn't know how my body would respond. While I knew that my weight gain was entirely due to Trikafta, I couldn't help but feel like I had failed myself. But I was robbed of the ability to pinpoint where I'd gone wrong. It would have almost been easier to accept if I had been stress eating or slacking off on exercise, but I hadn't made any lifestyle changes, yet I felt embarrassed. Now, anyone who knows me will tell you that I'm not someone who just accepts the status quo. When I was first diagnosed at 15, I made a promise to myself that I would never let CF hold me back. So I was determined to tackle this new challenge head on, and thus began my weight loss journey. I counted calories with every meal and increased my daily step count. I already live in a 4-story townhome, so stairs are a constant in my life, but I began taking the stairs even at work and walking to the grocery store instead of driving. I was fully committed and excitedly talked about my weight loss goals with my friends and family to increase accountability. With the level of enthusiasm and my dedication to calorie counting, my wife did worry I was overfixating, but I promised that really wasn't the case. My openness reflected my dedication and excitement in seeing results for something that I had never had to do before. And all my efforts were paying off. Within 4 months of beginning my program, I had lost 12 pounds and was only 2 pounds away from my goal weight. But then my life changed again when my daughter was born. As my wife and I were eating dinner in our hospital room the night before my daughter's birth, I habitually opened my calorie counting app to log the food, only to realize I probably had more important priorities at that moment. Since I knew I couldn't devote the same mental energy to weight loss with the stresses of new parenthood, I decided to put a temporary pause on my calorie counting. My interim goal was to maintain my current weight until a time when I could resume my regimen and lose the remaining pounds. Fortunately, I've kept most of the weight off, only gaining 2 pounds since I put a pause on my program 10 months ago. And now that my daughter is older, I've returned to my weight loss goals to finish what I had started a year ago. Although I am currently at a healthy weight and could stop here, I still want that sense of accomplishments and proving to myself that I can achieve and maintain my original target weight that was set between myself and the CF clinic. Now, even though my medical team has been incredibly helpful in jumpstarting my weight loss, I've personally studied plenty of online resources, and there are still unique nutritional and body image challenges that we CFers face, which simply aren't captured in generic weight loss material. Given the need to unlearn our previous dietary advice, it would be helpful to have educational resources comparing the before and after Trikafta nutritional advice for CF patients. Here are just a few open questions in my mind, which are not answered by any of the currently published literature. Do any of the previous CF recommendations remain? Or is the post-Trikafta advice to just follow the same nutritional guidance as anyone looking to lose weight? Should we continue to eat high sodium, high protein diets? Is there anything unique or challenging about weight loss with CF patients? Does Trikafta or other CF medications cause weight gain? Or are we all experiencing normal weight gain with the calorie intake and activity levels of a person without CF? And if the weight gain is even in part medically induced, does that impact diet and exercise recommendations? It goes without saying that both medical providers and CF patients have undergone a monumental shift in how we treat and live with cystic fibrosis. Acknowledging that shift and providing tailored guidance would be incredibly helpful as we all discover what Trikafta means for our long-term medical care. Thank you.
Okay. Any questions for our special guest? They'll be sticking around for the panel discussion in case you do. Otherwise, we'll move on with Aaron Scallery.
All right, good afternoon, everybody. It's funny, the yoga instructor in me wants to ask everybody to stand up and take a deep breath or something, but we're so glad that y'all are here. These are my objectives. And just like Dr. Foligno was mentioning, context is everything. And so it's important to share where I am coming from. And these represent a lot of unearned privileges that shape my experience and the way that I see things. I didn't realize it until this morning that I also have either a privilege or a bias because I came into CF Care in 2015. I never did the legacy diet with my pediatric patients. And so it was really great to hear Suzanne share kind of the history and things. And so I also have a different perspective because I didn't go through that with my patients. So we all entered healthcare to essentially be in this picture, right? We want the engaged family. We want them, learning. We want them engaged. And I love that the CF Foundation is so patient-centered and that we're making decisions as a team. In reality, I don't know about you guys, but a lot of conversations may look more like this. It can feel like a tug of war or we're pulling teeth. And the comment in the bubble is really interesting because as Dr. Foligno already mentioned, we want to be focusing on behavior change, not weight change. And I want to really acknowledge the 2023 nutritional considerations for a new era. A lot of the writers are here in this room. And so they actually set us on a really great path in recommending weight neutral care. So if you are not familiar, weight neutral care is a health approach that prioritizes improving physical, mental, and social well-being without using weight, BMI, or weight change as the primary measure of success. I know a lot of times when we take weight out, the instant thought is, well, we don't care about these people's health, and that is not the case at all when we're talking about weight neutral care. The evidence base for this, and I have 3 pages of reference slides, so you can have it, you can take pictures. There's a lot of data that we're gonna go through. So diets do not lead to sustained weight loss long-term. And when we're talking about long-term, we're talking beyond 3 to 5 years. And so 95% of the time, individuals who intentionally engage in behaviors to reduce their body weight, they are not successful long-term. Up to 66% of people will regain more weight than they lost. So the conversation about weight cycling was very, very timely because it is the most likely outcome for dieting. And again, a lot of times we see that word dieting, we think fad diets, we think Jenny Craig. This is any attempt to use behavior change to change your body. When we look at weight cycling, we actually see that it is more harmful than individuals who stay at a higher stable weight. That repeated loss and regain of body weight due to dieting restriction or external pressure to lose weight can impact our cardiovascular, metabolic health, and continue to make detrimental impacts on body composition. And ultimately, quality of life decreases with weight-focused interventions. I really appreciated both Alex and Matthew sharing their stories and how conversations about weight impact, but also sharing that it's important for us to have those conversations. One of the main reasons I would say that it's so hard to have conversations about weight is because of weight stigma, which also shows independent harms towards health. So if you have not heard the term weight stigma, I want to introduce you to it, and it's not me just coming up with this. I'm really fortunate that the Cystic, Fibrosis, Reproductive, and Sexual Health Collaborative, or CFRESH, actually started the conversation on weight stigma, citing that this is something that someone with CF could face. And of course, looking at the word stigma, it's going to be any discrimination based on body size, which harms well-being and impacts compassionate and evidence-based care. It distorts our individual perception, and it also is going to erode the trust in that patient-provider relationship, making it feel like this tug of war that we're all talking about. I don't know if you've ever gone into a room with the idea of how do I get them to. I'm always really sensitive. If I'm walking into a room saying, how am I going to get them to eat more vegetables or to exercise? Then I think, well, what if someone's trying to get me to do something? Like, I just get tensed up. Another thing we joke about is like, you don't want to should all over them. Right? All of the things that we need to be doing. I think the last point is also a really important one. As we're in an age of modulator therapy, it's already hard to get patients to come in. They're feeling better. And if they're experiencing weight stigma, they're going to be less likely to come and have conversations with us. So this isn't just about being nice. And I know that's how it can definitely feel like, oh, people are just sensitive, right? They need to get over it. They need to grow a tougher skin. I'd like you to have a moment and just kind of think, have you ever gone into a store and tried to buy clothing and they didn't have clothing that even fit you, or worry if you would fit in a bus seat? Like, all of these are examples of weight stigma that people face every day and impact our ability to live and function. I do want to point out that all of the commentary that I'm about to provide and the insight is not CF specific, but I would say that it is we could extrapolate to the CF population. I think we have weight stigma on both sides, from first being too small and needing to be bigger, and now feeling that our bodies are too big and needing to be smaller. So of course we have increased physiological stress. So we're gonna have elevated cortisol, we're gonna have inflammation, and then higher blood pressure. So again, it's really interesting to think about, is it weight? Is it weight stigma? How do we separate those two things out? Experiencing weight stigma predicts weight gain. So that's separate of calorie intake, all those kinds of things. It's going to predict weight gain and disordered eating, not weight loss. Again, our access to care is going to be delayed. People are going to avoid coming to appointments because they're concerned about either being shamed or being dismissed. It feels a little bit like darned if you do, darned if you don't, kind of in that situation. And then the frustrating fact that intentional weight loss rarely produces long-term health improvements, while cycling between loss and regain, or weight cycling, is linked to worsening metabolic outcomes. I think it's important to name that a desire for weight loss is a desire to find community, to find safety, and to find support. We don't have big teeth. We don't have claws. We find support in community. And when our bodies are othered, then we automatically want to change our bodies so that we can find safety. And I actually think it's really interesting in clinic to use that approach and thinking about the term non-compliance. Is it that our patients are in a defense mode, that they're shut down trying to find safety in that space? So weight stigma is prevalent in healthcare, in workplaces, in schools, and even within families. Some of it's very even cultural. So I live in Texas, so it's very common for kind of this nurturing comment to call it gordito or gordita, and so they're kind of fluffy or bigger. And yet I still look in my patient's eyes and see, how that can impact some of them. People in larger bodies experience discrimination that affects employment, medical care, and relationships. Like, it stinks to say, but if you are in a larger body, you're most likely going to be paid less than somebody else who is in a smaller one. And these are really, really real facts to consider as you're having a conversation with someone. Internalized stigma. So we're all swimming in this culture of weight stigma. It makes sense that we then internalize that message. That becomes our own message. And that's going to predict depression, anxiety, and disordered eating. And it's so easy to go to that disordered eating, right? There's so many assumptions about being in a larger body, right? You're eating too much, so I'm going to try to eat less. I'm going to skip breakfast. I'm going to skip lunch, right? And then I eat a lot at the end of the day, and I feel like a failure because I ate too much, and the cycle just continues. So how do we handle this dichotomy that exists where we have weight stigma? Weight is a neutral biological piece of data, right? Like, we take our temperature. Are we concerned when our temperature is elevated? I mean, I guess if we're feeling symptoms, but we're not going, oh my gosh, I shouldn't have eaten that cake last night. Look at what it did to my temperature, right? Same thing maybe with height. I mean, there's other neutral pieces of data that can inform our clinical experience, right? But at the same time, bodies are political, right? It is a place, human bodies are the sites where power, control, and social hierarchies are inscribed, contested, and displayed. So while weight is a neutral biological piece of data, it's also political, which makes this tension so difficult. People can change health behaviors and not experience sustained weight loss or a specific metabolic outcome, right? When we give advice in clinic to eat more fruits and vegetables, the assumed outcome would be if you ate more fruits and vegetables, you will lose weight. When your patient comes back and they're like, yeah, I've been eating more fruits and vegetables, but their weight trend is going up, do you doubt what they say? Those are all interesting questions to kind of think about, because I can advise people on behaviors all the time, but I can't guarantee what outcome they have. But I can believe my patient, right? Because if they're lying to me, that's a whole nother conversation that we need to have at that moment. I love the conversation around body composition. I think it is amazing. One of my biggest fears is we're just gonna swap body mass index for fat-free mass, okay? So people, whichever measurement of body, BMI, fat-free mass we want to use, we have different BMIs, we have different fat-free mass, and we also have different health statuses. So you could have someone in a large body who has perfect blood pressure and cholesterol and all those kinds of things, and you can have someone in a small body who has high blood pressure and high cholesterol. This is another hard one. CF modulator therapy helps body systems work better. And the change in bodies that come along with it, as we've already heard, make people feel like failures. I may even see it may make clinicians feel like failures, right? We worked so hard to help people live longer, healthier lives, and now it's like, oh no, what have we done to people now? And that dichotomy, I wish I had the answers. I love DBT because we can hold both truth equally, and it doesn't have to be one or the other. Ultimately, the response would be listen with curiosity. We are all trained to fix, right? Oh, you have this problem. Okay, you're constipated, take your Miralax, eat more fiber, drink more water, right? Sometimes we just need to pause and to listen. There's this great paper that you can look up, so the definition and diagnostic criteria of clinical obesity. So the proposal that is made in this paper is to move away from solely using BMI, which is great because we know that BMI is a crude population level tool. It ignores body composition, it ignores racial and ethnic and gender variation, and can also enforce stigma and denial of care. I do think it's interesting that for this paper, we don't solely use BMI unless they're over 40. If they're over a BMI of 40, then you don't have to look any further. So I'm curious about that. They recommend that we complement with waist measures or other body composition measures. And then we also have this classification system of clinical versus preclinical. Sorry, guys, with the mic, I'm trying to get close enough. Okay, or far enough away. So clinical obesity is excess body fat that has led to measurable functional impairment or damage to tissues, organs, or overall health. Where preclinical obesity is where we have a state of excess adiposity. However, there is no evidence that it's contributing to a functional impairment or organ damage. Not in this paper, but I think also important to know is that we have metabolically unhealthy normal weight, or also known as metabolically obese normal weight, with varying prevalence of all kinds of conditions from about 18 to 40% of the population. So I think that's a really interesting thing to think about when we're thinking about health and body size. Some additional considerations from the weight stigma perspective. Does defining body size as a disease make bodies purely clinical, right? That's the idea. When we make obesity a disease, then it's removing the stigma. Is it accomplishing that goal? That's not for me to answer. I think that's a good question to think about. As we're moving beyond BMI, what roles do stigma reduction, equity, and justice play as we look at what takes place? And then will using different measurements and illness-based markers decrease stigma? So if you're in a thin body, but you have insulin resistance, then, sorry, I got my 2-minute warning. I'm gonna have to fly here. Then a person in a thin body who isn't large is still going to feel pretty poorly about themselves. So bringing this into clinic, we always want to ask permission, okay? This is a great question to use if you're not quite sure how to phrase that question. The CF Foundation recommends monitoring. It doesn't say that we necessarily have to have that conversation about what it is to provide medical care. We do want to respect their answer, and if it feels okay, humbly kind of inquire what their concern is there. This allows an opportunity to kind of build that relationship. When we're looking at reviewing trends in clinic, these are all really great points. I'm going to share slides for the dietitians on the listserv, but again, using neutral language and focusing on behaviors and function. It's important to normalize variation. Bodies come in different sizes and shapes. The mention of Ellen Satter was made earlier, and so this is a really, really great tool to look at the growth chart. It is meant to be a population tool. And so we look at an individual's trends. I loved what Amanda Leonard said earlier, that you're the perfect size for insert whatever the patient's name is today. So like, you're the perfect size for a Susie today. And if you're seeing trends, we can kind of have conversations from there, not in a judgmental way, but noticing, has something changed in their life? Are they experiencing food insecurity? There's so many doors that can be opened in a conversation. Ultimately, behaviors matter more than body size. That is just the takeaway. And as we're looking at the different behaviors, I would be curious about how weight stigma impacts each one of these. Because if you're telling me I have to exercise so that I can lose weight, maybe short term I'll do it, but that feels punishing. We don't tend to keep up things that are self-punishing. We keep up things that are self-care. The question of if weight loss is needed for clinical reasons, these are really good questions to kind of go through and think. The main one is, if you had a thin patient with this same condition, what would you recommend? So if you want to recommend weight loss, that's awesome, but give the exact same advice that you would give to a thin patient. Otherwise, you've provided a different intervention. When we provide a different intervention, we can't be surprised that there's a different outcome. When we have patients who want to lose weight, keep in mind a lot of that is to experience less stigma. I want to wear cute clothes. I want to be able to purchase clothes wherever, I can. And ultimately, it still comes back to behavior, and you still have the opportunity to praise the behavior and inform them that, we believe you, right? I love this quote. I think it's just captures everything. I went over time. Sorry, guys. Thanks for your attention.
We're going to invite Matthew and Alex to join us on the panel discussion here. Hey, Matthew. You cannot see us, but you have a room full of clinical providers here. And what I'd like to first appreciate your bravery for sharing your story. And then I'd like for you to recommend or tell us what is one thing that the clinical providers could have done in your case to help you manage your weight change journey. Either Matthew or Alex.
I'm still thinking if you're ready, Matthew, but.
Yeah, sure. I think acknowledgement of the difference in the nutritional advice for CF would have been really helpful. So for me, as I mentioned, I became very introspective as I kind of looked at my body, and I was unhappy with how it had changed. And so I think just that reassurance of, hey, this was the previous guidance. Trikafta's the cause here. It's absolutely nothing to do with your eating habits, but here's kind of how we can tackle that moving forward. I think those words of assurances would have made me feel a little bit better and get out of my own head.
One thing that really helped me when I was just having all the other side effects of Trikafta is that first visit I had where I listed all my side effects. I remember my doctor, everyone I said, he would say, oh, yep, we've heard that one. We've heard that one. And it just, whether it was true or not, it made me feel like I wasn't alone. And at that point, I hadn't quite had that weight gain yet. So by the time the weight gain started happening, it would have been great if they had said, don't worry, other people are gaining weight too. I feel like people with CF, a lot of times we feel so alone and isolated as it is, that just knowing there's other people out there in the world that understand what we're going through and get it, whether we've met them or not, just knowing other people know our struggles and are going through them as well is just really helpful.
Well, thank you both for your feedback. And if anybody has any questions for us, feel free to come up and speak into the mic. We do have several questions online.
One of the questions for the entire panel, do you feel that weight-inclusive approaches and GLP-1s can be used in tandem? I'm keen to hear everyone's perspective, and if you feel this is feasible, what is your best advice for implementing this model in a busy and under-resourced CF clinic?
I have the least to say. Do you want me to go first? Sure. Okay. So from a psychologist standpoint, I would put this in the framework of shared decision-making. And so ethically, if there are interventions available that have advantages, even if the ratio advantages to disadvantages is maybe tipped in a not entirely desirable way, we still want to include them in the menu of shared decision-making options. Using open-ended questions to solicit feedback from the people who are going to make the decisions.
We have some, go ahead.
No, I was going to say that I do think they can be used in tandem, especially in our CF population, because for someone that actually does prescribe GLP-1s to our CF patients, we do take it very slow, and it's not typically a weight-based goal. It is the adult patient that is uncomfortable with how he's feeling, bloated in the abdomen and just kind of wants to feel better, and it's not necessarily about that weight goal. So I do think they can definitely be used in tandem.
I would also agree. I think informed consent is really important. So telling someone before they start on a GLP-1, there are non-responders. So you could take it and you may not lose any weight. That's one of the really big challenges with weight-focused interventions is when you try and then you don't have the desirable weight response. It's the individual who feels like a failure versus the product or what you're trying to do. Another really important thing to name, as a dietitian who works with people with eating disorders, I use eating disorder treatment on my GLP-1 patients because they no longer have hunger and, hunger at all. Well, some of them are okay, but we typically do mechanical eating and it's like you don't have hunger cues, but you still need to eat. So that's something else to consider.
I think it's certainly possible to use these two approaches in tandem. For me, my weight goal would be for a man, BMI 23 to 30, for a woman, 22 to 30. I don't really care too much as long as kind of they're around that range. I think they're doing well in terms of their lung function. And we do have a question over here. Yes.
Yeah. Alex and Matthew?
Hi, Alex and Matthew. Can I go?
Oh, we had a question about the response from the patient. So the question for Alex and Matthew is there did you prefer to hear kind of a weight goal, or would you like to hear a different approach when you're put on these weight loss medications? How do you best receive that information?
For me personally, I actually prefer a weight goal and a number because it's something tangible that I can work towards. I definitely understand trying to structure it as health instead of weight, but that isn't tangible to me. I can't figure that out, but if there's a number and I can get to it, then it's a goal that I can meet.
I actually feel very similarly. I was going to say the same thing. I work in tech as a product manager, so I'm a numbers and goals kind of guy, and I set processes for my teams. And so for myself personally, it's actually really helpful to say, this is the goal I'm trying to hit. I'm going to track my KPIs as I go through the process, to use my work jargon. So for me, actually, a more holistic, just, increase your activity. I don't like those type of amorphous things for myself. So for me, it would actually be really helpful to have the goal and kind of milestones as we get there so that I can try to hit those myself.
Thank you.
Jason.
We have an in-person question.
Hi, Alex and Matthew. My name's Kelly. I'm a dietitian from Salt Lake City. And I wanted to say thank you to both of you for sharing your experiences, especially the parts that were really hard where your team, it sounds like, let you down to some degree. That's so helpful for us to hear as providers. So first, I want to say thank you for sharing. Secondly, I'm sorry for for your experience and the pain that you both went through as you transitioned onto this drug and the experiences you had on it. And it sounds like your needs weren't met. And here's my question for you. When you've had, and this is my wording, so I'm not sure you would put it this way, but when you've had perhaps a loss of trust in your provider or you felt let down by them, especially with the dietitian, what could your provider do now to help build that relationship?
I do want to stress first that my CF doctor was amazing. I have absolutely no complaints about him. He was fantastic and was very there for me. We just didn't know why I gained so much weight. It was more of a confusion, but I didn't feel blamed by him. It felt very much when we were working together. So for me, a lot of it came on the dietitian side, because it was very much, let's talk about what you're eating, and that was it, which left me to think, oh, I'm eating too much, so it's my fault. And it wasn't a way to reframe how I've eaten my entire life. It was just stop eating that. It feels like, I don't know if this is in other people's clinics, but the dietitian in general at the CF clinics I went to in Texas and now Colorado, it's kind of a revolving door. That specific job, I have probably had 6 or 7 dietitians at my clinic since I've lived in Colorado for the last 9 years. So it is hard to have that trust anyway for me. And it feels like I have to explain my story all over again to every single one. So it's harder for me to answer this question because I actually didn't see that dietitian very often again, and they've already moved on. So I never really had to talk to them again about, I felt that they let me down because they just moved on to a new position kind of right away.
Thank you. And one more in-person question.
Oh, sorry, go ahead, Doctor.
Yes.
Sorry, I didn't mean to interrupt. So I'm actually not a clinician. I'm a CF mom. I just want to thank you both for sharing your experience. I have a 10-year-old daughter with CF, and when she was 8, she went from the child dose of Trikafta to the full dose due to an exacerbation. And in 3 months, she gained 30 pounds, which for an 8-year-old is a lot. And I felt a lot of struggle in communicating with her care team about this because the concern was more that she was getting the benefits of Trikafta for her lungs over the weight gain. And now at 10 years old, her weight gain has slowed, but it's still very much an issue. And very much, I see the body image issues coming up. And so my question, I guess more for the clinicians, is just at what point, where's the fine line of talking to the parents about it and still being sensitive to the age of the child? Because, you know, at 8 and 10 years old, they're still developing how they feel about their bodies, and a lot of changes are happening. And as a parent, you don't want to exacerbate that. You don't want to make them feel bad for the weight gain, but she eats healthy, she exercises, she's on the go all the time. And I know for a fact it was the medication. It wasn't any lifestyle changes. So thank you.
Yeah, thank you for that really great question. And I think while we're really sensitive about this for a child of this age, it really does generalize to anyone at any age. And I think it's the recognition that bodies change throughout the course of a lifetime. And this was somewhat unexpected in its magnitude, but it does, even though it's a hard opportunity, is still an opportunity to learn how to have conversations about body changes, right? So this wonderful kiddo is getting ready to be headed towards puberty soon, and there's another whole set of changes that are going to happen. So I think it would be a great opportunity to talk to a clinician who's comfortable and skilled in this area about like what are the words that we use and how do we talk about this as a family? How do you develop the vernacular about feelings and all kinds of like feeling labels, and how we learn to trust and respect our body when sometimes it feels so out of our control.
Oh, one resource for you and your daughter, there's the virtual field trip, Amazing Me. It's geared for like 4th and 5th graders, which is really great. It is complicated to have those conversations. And I feel you so much. My daughter was diagnosed with type 1 diabetes. She started on insulin, and like the next checkup was like, you better watch her weight. And I'm like, crap, I'm just feeding her. It's such a struggle there. And so just want to validate that. And also the feeling that as a parent, right? Like it almost feels like we're failing them because of those body changes, which just holding so much space and compassion and trying to look beyond body size as your measure of how you care for your daughter, which is hard in today's society.
Thank you for your question. One last in-person question.
Thank you very much. Matthew and Alex, thank you guys so much for sharing. It's really, really awesome to hear case reports of patients and the honest truth about what's working and not working in clinics. I'm Carissa, I'm the dietitian at UW. And something that I try to be really cognizant of in my practice is the burden of care in CF. People have different priorities, whether it's the diabetes care or their pulmonary function or nutrition. And broaching the subject of, do you want to talk about your weight with me, is always like a fine line to walk. And we know our patients quite well, so we tend to know who's open to that and not. And something I want to hear from you guys is, it sounds like both of you were very interested in like placing weight as a high priority, and you were very curious in your own lives about how to address it. But from your CF team, who provides you a lot of care for a lot of different things, what I want to know is how much would you expect or want from your dietitian or anyone else on your team to be with you along this way, to check in with you? How much is an overburden of care when it comes to weight management? Because we know, I think a lot of providers in this room are quite sensitive to like trauma-informed healthcare. We know from pediatric age, especially for our older adults, there have been like nutrition-related trauma. So it's sometimes a fine line to walk. So I'm very curious if you guys have opinions about how much you want from your providers.
Thank you so much for the question. For me personally, I actually like a more proactive approach. So in my case, I actually went to my CF medical team and said, hey, I've been noticing this weight gain. I'm not sure if it's, within the healthy range still. Can we do something about it? And I think it would have been helpful for me to actually have a more proactive discussion, even if my CF team mentioned it on their own at clinic visits prior to me bringing it up. Because as I mentioned, I had never really thought about weight prior to Trikafta. So for me, I actually had no idea what was a healthy weight range for myself and when should I start taking actions to increase activity, look at what I'm eating and try to head it off before I have to lose, 30 pounds. So I'd say a more proactive approach, and having the clinics mention it to me would have been really helpful.
I completely agree with Matthew. And it is, as I said earlier, it's such a sensitive topic, and I completely understand why, people at clinic don't want to bring it up, but it's kind of the elephant in the room, no pun intended. But if you're sitting in the room with a patient who has gained obviously a lot of weight since they've been on a medication, trying to tiptoe around it and asking them how they're feeling, trying to get to the root of the problem, but without just saying and I don't know, I'm sure there's a lot of patients where you can't just say, hey, I think you've gained some weight, but maybe even just bringing up the Trikafta in general. You know, I've heard Trikaftas making some people uncomfortable in their own body. Have you had experienced that? And maybe approaching it that way, as we understand that there's a medication that is making people gain weight, and approaching it as it's the medication's fault, so to speak, instead of their fault, I think would make a huge difference.
Well, thank you all for coming, and I want to thank all of our panelists for creating this engaging session for everybody here today. Thank you.
Thank you so much for having me. Something want to say.